Management of Breech Presentation. Green Top Guideline Number 20B, March 2017. Introduction and Background Epidemiology. Breech presentation occurs in 3 to 4% of term deliveries and is more common preterm. It is associated with uterine and congenital abnormalities, has a significant recurrence risk, and is more common in nulliparous women. Term babies presenting by the breech have worse outcomes than cephalic ones, irrespective of the mode of delivery. Publication of the term breech trial, or TBT, was followed by a large reduction in the incidence of planned vaginal birth. Publication of the term breech trial, or TBT, was followed by a large reduction in the incidence of planned vaginal birth. Nevertheless, vaginal breech births will continue, not merely because of failure to detect breech presentation and the limitations of external cephalic version, but for reasons of maternal choice. Lack of experience has led to a loss of skills essential for these deliveries. Conversely, caesarean section can have serious long-term consequences. What information should be given to women with breech presentation at term? Women with a breech presentation at term should be offered external cephalic version, or ECV, unless there is an absolute contraindication. They should be advised on the risks and benefits of ECV and the implications for mode of delivery. Women who have a breech presentation at term following an unsuccessful or declined offer of ECV should be counseled on the risks and benefits of planned vaginal breech delivery versus planned caesarean section. What information about the baby should be given to women with breech presentation at term regarding mode of delivery? Women should be informed that planned caesarean section leads to a small reduction in perinatal mortality compared with planned vaginal breech delivery. Any decision to perform a caesarean section needs to be balanced against the potential adverse consequences that may result from this. Women should be informed that the reduced risk is due to 3 factors: the avoidance of stillbirth after 39 weeks of gestation, the avoidance of intrapartum risks, and the risk of vaginal breech birth, and that only the last is unique to a breech baby. Women should be informed that when planning delivery for a breech baby, the risk of perinatal mortality is approximately 0.5 per 1,000 with caesarean section after 39 plus 0 weeks of gestation, and approximately 2.0 per 1,000 with planned vaginal breech birth. This compares to approximately 1.0 per 1,000 with planned cephalic birth. Selection of appropriate pregnancies and skilled intrapartum care may allow planned vaginal breech birth to be nearly as safe as planned vaginal cephalic birth. Women should be informed that planned vaginal breech birth increases the risk of low APGAR scores and serious short-term complications, but has not been shown to increase the risk of long-term morbidity. Clinicians should counsel women in an unbiased way that ensures a proper understanding of the absolute as well as relative risks of their different options. The term Breech trial or TBT randomized 2,088 women to either planned cesarean section or planned vaginal birth at 121 centers in 26 countries. This trial was by far the major contributor to the Cochrane Review, which demonstrated a reduction in perinatal mortality with planned cesarean section from 1.3 to 0.3%. This trial also reported a reduction in the composite outcome of serious neonatal morbidity. Elective cesarean section exerts a protective effect on perinatal mortality as well as short-term but probably not long-term morbidity, although the effect is smaller than suggested by the term Breech trial or TBT. Some of the risk is due to the earlier gestation at which elective cesarean section is performed, while some is due to the elimination of labor, which even for a cephalic baby can lead to mortality. The excess risk of breech compared with cephalic labor is relatively small, 1 per 1,000, and implementation of strict selection and intrapartum management criteria, together with skilled support, may reduce it further. Perinatal mortality is also slightly increased by vaginal birth after cesarean section or VBAC, which nevertheless remains a common option. Any benefit from elective cesarean section must be viewed in the light of the small increase in complications associated with subsequent pregnancies. Furthermore, cesarean birth has been associated with long-term health issues in the offspring. What information should women having breech births be given about their own immediate and future health? Women should be informed that planned cesarean section for breech presentation at term carries a small increase in immediate complications for the mother compared with planned vaginal birth. Women should be informed that maternal complications are least with successful vaginal birth. Planned cesarean section carries a higher risk, but the risk is highest with emergency cesarean section, which is needed in approximately 40% of women planning a vaginal birth. Women should be informed that cesarean section increases the risk of complications in future pregnancy, including the risk of opting for vaginal birth after cesarean section or VBAC, the increased risk of complications at repeat cesarean section, and the risk of an abnormally invasive placenta. Women should be given an individualized assessment of the long-term risks of cesarean section based on their individual risk profile and reproductive intentions, and counseled accordingly. Maternal outcomes, particularly short-term, depend on the category of lower segment cesarean section, with emergency carrying a higher risk than elective. Emergency cesarean section rates with planned vaginal birth vary from 29% to 45%. For subsequent pregnancies, having had a planned cesarean compared with planned vaginal birth causes a threefold increase in uterine scarring, More than half of all women with at least one prior cesarean section have another. The risks of blood transfusion, endometritis, hysterectomy, and death are increased in women with a previous cesarean section, irrespective of whether they attempt a vaginal birth after cesarean section, when compared with those who have previously delivered vaginally. The risk of scar rupture during attempted vaginal birth after one cesarean section is approximately 0.5%. In developing countries, particularly where birth outside hospital is usual and access to healthcare is poor, the effect on maternal outcomes is likely to be considerably greater. A further maternal issue is that of placenta previa and placenta accreta, or abnormally invasive placentation, for which prior cesarean delivery is the principal risk factor. The risk of abnormally invasive placentation increases from 0.31% with one prior cesarean section to 2.33% with four, and the incidence is rising. The risk is higher after elective compared with emergency cesarean section. This complication can lead to massive hemorrhage, hysterectomy, urinary tract injury, and maternal death. What information should women having breech births be given about the health of their future babies? Women should be informed that cesarean section has been associated with a small increase in the risk of stillbirth for subsequent babies, although this may not be causal. Future pregnancies are also at risk of uterine rupture when vaginal birth after cesarean section is attempted. The risk of delivery-related perinatal mortality after one cesarean is up to 12.9 per 10,000, much of which is attributable to uterine rupture. What factors affect the safety of vaginal breech delivery? Antenatal assessment. Following the diagnosis of persistent breech presentation, women should be assessed for risk factors for a poorer outcome in planned vaginal breech birth. If any risk factor is identified, women should be counseled that planned vaginal birth is likely to be associated with increased perinatal risk and that delivery by cesarean section is recommended. Women should be informed that a higher risk planned vaginal breech birth is expected where there are independent indications for cesarean section and in the following circumstances: hyperextended neck on ultrasound, high estimated fetal weight more than 3.8 kilograms, low estimated weight less than 10th centile, footling presentation, and evidence of antenatal fetal compromise. The role of pelvimetry is unclear. The safety of planned vaginal breech birth is dependent on case selection, operator skill, and intrapartum management. There is, however, a paucity of good evidence regarding factors that increase the risk of vaginal breech birth. Skill and experience of birth attendant. The presence of a skilled birth attendant is essential for safe vaginal breech birth. Units with limited access to experienced personnel should inform women that vaginal breech birth is likely to be associated with greater risk and offer antenatal referral to a unit where skill levels and experience are greater. Although largely unproven, the availability of skilled personnel is likely to strongly influence perinatal outcomes. An inability of a unit to reliably provide experienced personnel for the delivery is a contraindication to a recommendation of planned vaginal birth. Intrapartum assessment and management of women presenting unplanned with breech presentation in labor. Where a woman presents with an unplanned vaginal breech labor, management should depend on the stage of labor, whether factors associated with increased complications are found, availability of appropriate clinical expertise, and informed consent. Women near or in active stage of labor should not be routinely offered cesarean section. Where time and circumstances permit, the position of the fetal neck and legs and the fetal weight should be estimated using ultrasound and the woman counseled as with planned vaginal breech birth. All maternity units must be able to provide skilled supervision for vaginal breech birth where a woman is admitted in advanced labor, and protocols for this eventuality should be developed. UK data reported that breech presentation at term is not diagnosed until labor in about 25% of women. In some women, labor will be so quick that vaginal breech birth is inevitable and assessment using ultrasound is impossible. Unplanned vaginal breech birth is associated with increased risk, but the data on planned vaginal birth cannot be simply extrapolated to support routine late labor cesarean section. Where labor is progressing rapidly, there is a balance of risk. Attempting cesarean section where the breech is very low is likely to be associated with increased perinatal and maternal risk. Assessment should include what is feasible. Attempts at vaginal delivery in theater with spinal anesthesia or cesarean section with a breech on the perineum are likely to be associated with both increased perinatal and maternal risk. What is appropriate intrapartum management of the term breech? There is a paucity of evidence regarding the best management of the breech fetus in labor. Recommendations are based on physiology, best practice experience, and the management protocols of series with low complication rates. The limited evidence and expert opinion broadly divides into two groups. A more interventionist approach supported by data from the large pre-MODA study, and a less medicalized approach which is more traditional in the UK. Both strategies advocate close supervision and the not infrequent need for cesarean section or intervention during breech birth. Are induction and augmentation appropriate? Women should be informed that induction of labor is not usually recommended. Augmentation of slow progress with oxytocin should only be considered if the contraction frequency is low in the presence of epidural analgesia. As a means to treat dystocia, augmentation should usually be avoided, as adequate progress may be the best evidence for adequate fetal-pelvic proportions. However, if epidural analgesia has been used and the contraction frequency is low, its use should not be excluded. Notably, labor augmentation is not supported by many experienced advocates of vaginal breech birth who favor a less interventionist approach. What is the role of epidural analgesia? Women should be informed that the effect of epidural analgesia on the success of vaginal breech birth is unclear, but that is likely to increase the risk of intervention. Vaginal breech birth is usually easier if a mother is able to bear down effectively, and an epidural may interfere with this. A less interventionist approach advocates a calm atmosphere with continuous support as a means to avoid epidural analgesia. With a more interventionist approach, seldom used in the UK, epidural analgesia is less likely to have a detrimental effect. What fetal monitoring should be recommended? Women should be informed that while evidence is lacking, continuous electronic fetal monitoring or EFM may lead to improved neonatal outcomes. Breech presentation is associated with an increased risk of cord prolapse. During delivery, cord compression as the head enters the pelvis is common. This is likely to be better tolerated by a fetus that is not hypoxic. Equally, good fetal tone enables easier breech birth and is more likely in a non-hypoxic fetus. While good evidence is lacking and higher intrapartum caesarean section rates should be expected, electronic fetal monitoring is likely to improve neonatal outcomes. Where EFM is declined, intermittent auscultation should be performed, as for a cephalic fetus, with conversion to EFM if any abnormality is detected. Where EFM or electronic fetal monitoring is considered abnormal before the active second stage, cesarean delivery is recommended unless the buttocks are visible or progress is rapid. Fetal blood sampling of the buttocks, although technically possible, is not recommended. Where should vaginal breech birth take place? Birth in a hospital with facilities for immediate cesarean section should be recommended with planned vaginal breech birth, but birth in an operating theater is not routinely recommended. Labor complications, including the need for cesarean section, in up to 45% of women are more common with breech presentation. Birth in water is not recommended due to the lack of gravity and difficulty anticipated if intervention during breech delivery is required. What guidelines should be in place for the management of breech birth? Women should be informed that adherence to a protocol for management reduces the chances of early neonatal morbidity. The essential components of planned vaginal breech birth are appropriate case selection, management according to a strict protocol, and the availability of skilled attendants. A Cochrane review of expedited versus conservative approaches to breech delivery found no studies that address this issue. Accepted principles, however, are established. These include assisted breech delivery rather than breech extraction and continuous support for and communication with the mother. Management of the first stage and passive second stage. Adequate descent of the breech in the passive second stage is a prerequisite for encouragement of the active second stage. The first stage of labor should be managed according to the same principles as with a cephalic presentation. To reduce the risk of cord compression, amniotomy is reserved for definite clinical indications. Where the progress is slow, caesarean section should be considered. In the presence of epidural analgesia and a contraction frequency of fewer than 4 in 10, however, oxytocin may be considered. A passive second stage to allow the descent of the breech to the perineum prior to active pushing is recommended. If the breech is not visible within 2 hours of the passive second stage, caesarean section should normally be recommended. What position should the woman be in for delivery during a vaginal breech birth? Either a semi-recumbent or an all-fours position may be adopted for delivery and should depend on maternal preference and the experience of the attendant. If the latter position is used, women should be advised that recourse to the semi-recumbent position may become necessary. Compared with the dorsal supine position, the all-fours position considerably increases pelvic dimensions on magnetic resonance imaging. Delivery with the woman in a forward-facing position or squatting or all-fours is the position favored by many experienced operators, claiming particularly that it is easier to observe for signs that the delivery will be more difficult. The principal difficulty with an all-fours position is when maneuvers are required. Most obstetricians are more familiar with performing this in a difficult breech birth with the woman in a dorsal position. If a woman chooses a forward-facing position, they should be made aware that if interventions are required, they may be given assistance to move into a dorsal recumbent position. Maneuvers in an all-fours position can be performed, however, and if the operator has the skills of undertaking the maneuvers with the mother in a forward position, this should be performed without delay. What are the principles for the management of active second stage and vaginal breech birth? Assistance without traction is required if there is delay or evidence of poor fetal condition. All obstetricians and midwives should be familiar with the techniques that can be used to assist vaginal breech birth. The choice of maneuvers used, if required to assist with delivery of the breech, should depend on the individual experience and/or preference of the attending doctor or midwife. While involuntary pushing may occur earlier, encouragement of maternal effort should not start until the breech is visible. Once the buttocks have passed the perineum, significant cord compression is common. Traction should also be avoided. A hands-off approach is required, but with appropriate and timely intervention if progress is not made once the umbilicus has delivered or there is poor tone, extended arms, or an extended neck. Tactile stimulation of the fetus may result in reflex extension of the arms or head and should be minimized. Care must be taken in all maneuvers to avoid fetal trauma. The fetus should be grasped around the pelvic girdle, not soft tissues, and the neck should never be hyperextended. Selective rather than routine episiotomy is recommended. Signs that delivery should be assisted include lack of tone or color, or delay, commonly due to extended arms or an extended neck. In general, intervention to expedite breech birth is required if there is evidence of poor fetal condition or if there is a delay of more than 5 minutes from delivery of the buttocks to the head or of more than 3 minutes from the umbilicus to the head. The semi-recumbent position. There is little comparative evidence regarding techniques of assisted breech delivery. If the back starts to rotate posteriorly, gentle rotation without traction should be used to ensure that it remains anterior. Once a scapula is visible, the arms can be hooked down by inserting a finger in the elbow and flexing the arms across the chest, or if nuchal, Loveset's maneuver is advised. Delivery is achieved either with the Morisot-Smellie-Witt maneuver or with forceps. Suprapubic pressure will aid flexion if there is delay due to an extended neck. Delivery using the Burns-Marshall technique is not advised due to concern of overextension of the fetal neck. An alternative is the routine use of the Brecht maneuver. Following spontaneous delivery to the level of the umbilicus, the body is grasped in both hands, keeping the legs flexed against the baby's abdomen, and without traction, is brought up against the symphysis pubis, frequently accompanied by a suprapubic pressure. The all-fours position. The limited evidence suggests that spontaneous delivery without assistance will occur more often. Management of the preterm breech. How should preterm singleton babies in breech presentation be delivered? Women should be informed that routine caesarean section for breech presentation in a spontaneous preterm labor is not recommended. The mode of delivery should be individualized based on the stage of labor, type of breech presentation, fetal well-being, and availability of an operator skilled in vaginal breech delivery. Women should be informed that cesarean section for breech presentation in a spontaneous preterm labor at the threshold of viability, 22 to 25 plus 6 weeks of gestation, is not routinely recommended. Women should be informed that planned cesarean section is recommended for preterm breech presentation where delivery is planned due to maternal and/or fetal compromise. Breech presentation is more common preterm and most preterm deliveries are unplanned as a result of a spontaneous preterm labor. The evidence regarding term breech should not be extrapolated directly to preterm breech delivery. Rates of perinatal morbidity and mortality are higher following a preterm delivery, irrespective of the mode of delivery. Several retrospective cohort studies have evaluated the relationship between low birth weight and breech delivery. Caesarean delivery was associated with a survival benefit across all birth weights, but morbidity was higher in the caesarean section group. Up to 25% of all preterm deliveries are iatrogenic due to antenatal complications such as preeclampsia, fetal growth restriction, and antepartum hemorrhage. For women requiring planned delivery for maternal and/or fetal compromise with a viable fetus in breech presentation, elective cesarean section is recommended. The poor outcome for very low birth weight infants is mainly related to complications of prematurity and not the mode of delivery. In the absence of robust evidence that a preterm baby presenting by the breech needs to be delivered routinely by immediate cesarean section, the decision about mode of delivery should be made by an experienced obstetrician following a thorough clinical evaluation and in consultation with the woman and partner. The stage of labor is critical. The course of preterm labor may be protracted and unpredictable. Immediate cesarean section may lead to earlier delivery than vaginal and might hinder the effect of steroids or prevent the use of magnesium. Likewise, it is prudent to reassess the patient in theater immediately prior to cesarean section in order to avoid the unfortunate situation where the uterus is found to be empty with the fetus already delivered vaginally. How should labor with a singleton preterm breech be managed? Labor with a preterm breech should be managed as with a term breech. Where there is head entrapment, incisions in the cervix, vaginal birth, or vertical uterine incision extension, cesarean section may be used, with or without tocolysis. Evidence concerning the management of preterm labor with a breech presentation is lacking. Routine amniotomy should be avoided. A specific problem encountered during preterm breech delivery is delivery of the trunk through an incompletely dilated cervix. This occurs in up to 14% of vaginal deliveries. In this situation, lateral cervical incisions have been used to release the aftercoming head. The RCOG Strat-OG program recommends incisions at 2, 6, and 10 o'clock. Similar rates of head entrapment have been described for vaginal and abdominal delivery. For head entrapment at cesarean delivery, it may be necessary to extend the uterine incision to a J shape or inverted D. Management of the twin pregnancy with a breech presentation. How should a first twin in breech presentation be delivered? Women should be informed that the evidence is limited, but that planned cesarean section for a twin pregnancy where the presenting twin is breech is recommended. Routine emergency cesarean section for a breech first twin in a spontaneous labor, however, is not recommended. The mode of delivery should be individualized based on cervical dilatation, station of the presenting part, type of breech presentation, fetal well-being, and availability of an operator skilled in vaginal breech delivery. Almost half of all twin pregnancies will deliver preterm, and decisions regarding mode of delivery need to be made in that context. If preterm delivery has not occurred, delivery from 37 weeks of gestation is now recommended. How should a second twin in breech presentation be delivered? Routine cesarean section for breech presentation of the second twin is not recommended in either term or preterm deliveries. The second twin is non-vertex at the time of delivery in about 40% of twin pregnancies. The presentation of the second twin at delivery is not always predictable. The chance of cephalic delivery may be improved by routinely guiding the head of the second twin towards the pelvis during and immediately after delivery of the first twin. On the other hand, some attendants prefer to routinely expedite delivery of the second twin by internal version and breech extraction irrespective of the presentation. There is no evidence as to which is safest. What organizational and governance arrangements should be in place to support a routine vaginal breech delivery service? Simulation equipment should be used to rehearse the skills that are needed during vaginal breech birth by all doctors and midwives. Guidance for the case selection and management of vaginal breech birth should be developed in each department by the healthcare professionals who supervise such births. Adherence to the guidelines is recommended to reduce the risk of intrapartum complications. Departments should consider developing a checklist to ensure comprehensive counseling of the women regarding planned mode of delivery for babies presenting by the breech.